Ghana's maternal health issues are exacerbated by the challenging state of the country's health systems. It is estimated that 10 to 15% of pregnant women develop complications that necessitates obstetric care and 5% require some type of surgery. The health infrastructure and systems are, however, unequal to the task. Many hospitals and health centers lack the required equipment and facilities for emergency surgery or life-saving blood transfusions. The large numbers of patients also puts pressure and physical stress on doctors and nurses, sometimes leading to lapses in patient care. This evening, we visit a hospital that has over the years confronted most of these challenges head-on, Korle Bu, currently Africa's third largest hospital and Ghana's leading referral center. Korle Bu was established in 1923 and has grown from an initial 200-bed capacity to 2,000. It leads in the provision of specialist health services. Our roving team gives us a unique view of the maternity ward, one of the busiest wards in a hospital that literally barely stops to take a breath. It is early morning at Korle Bu, Ghana's leading hospital. Patients gradually filter in, but it is already busy and getting quite hectic at maternity, one of the busiest and most eventful wards at the hospital. Kwale was brought in last night, but had to wait her turn at the operating theater. Her pregnancy had gone beyond the normal term, complicated by the fact that her baby is in the wrong position. Only a cesarean operation could deliver her baby safely. The surgeon proceeds diligently but swiftly, and the baby comes out and takes his first breath. Now Kwale is shown her son. It is a successful operation. In another part of the maternity ward, another mother is gradually losing concentration and getting weaker. Complications have set in after surgery. She also needs urgent attention.
Father, you will see them through. And those who are going to labor ward, Father, you have brought them back here. I thank you because I know you are a faithful Lord. Amen.
Amen. Another baby is weighed and measured, one of the thousands delivered every year at this overcrowded facility. Korle Bu does not lack skilled personnel. Its challenges relate more to the lack of adequate space and administrative pressures.
The doctors are available, space is not available.
We end up even having floor patients. So you have so much to put through the system.
There are 5 teams of doctors in the department. Each team has at least 4 consultants. Then there are 2 or 3 specialists. And then we have 3 or 4 postgraduate doctors in training, we call them residents. And also have 4 or 5 house officers, those who have just finished school and now being groomed to become doctors. Last year, our maternal mortality ratio was in the order of about 800 per 100,000.
How do you explain the numbers of maternal deaths that come out of Korle Bu if you have teams that are able to manage?
Most of the women who come in to die in this department die from 3 major problems. 1, from hemorrhage. 2, from complications of hypertension in pregnancy. And 3, complications of abortion. Hemorrhage is excessive bleeding during delivery. And if the woman comes in late, we first have to resuscitate her. You may not know her blood group. So we resuscitate her, take blood sample for her group to be checked and cross-match against stored blood. Many times, patients come in at a time that the blood bank is dry. There's no blood. And in that situation, it's very, very difficult for us to save the patient.
Most of the deaths are referred cases. most of them who do come in die within 24 hours.
It can be challenging when somebody is right in an emergency and you don't know anything about her. You are at a greater advantage if you know some of the challenges or peculiarities about these patients so that you can prepare yourself for the task. We lost about 150 women in this hospital last year, and it's not getting better this year.
The pressures on Korle Bu increase daily, but nothing takes away the joy of a mother after a successful delivery.
Hello, good evening, and welcome to the discussion segment on the Maternal Health Channel. Today, we take a look at the state of preparedness for maternal health delivery at our premier hospital, the Korle Bu Teaching Hospital. On my immediate right to inform and enrich this discussion, I have Professor Samuel Obed, who heads Obstetrics and Gynecology at Korle Bu. Prof, you're most welcome.
Thank you, Neil.
And on my left, I have Dr. Nicholas Kanlinsi of Engender Health. You're also welcome.
Thank you.
Now, Prof, let me start with you. Can you give us a picture of what really exists and pertains at Korle Bu?
As you all know, Korle Bu Teaching Hospital is a very busy place, and the maternity wing is probably the most busy place in the hospital. We normally do between 35 to 40 deliveries in a day.
Okay.
And the two labor wards we have a capacity of 15 delivery beds. Mm-hmm. And therefore, implies that most of the time, all these beds are occupied, and probably with some women lying on the floor. Mm. Okay. We have enough doctors to cover this service, but nursing and midwifery aspect is very much lacking. Mm-hmm. Right. There are experienced midwives who are retiring, and the young ones are not willing to join the service because of the severity of the work there.
Let me take you back, Prof, to what you said about the number of beds and the capacity of your unit or your department. As the premier hospital, does it mean that if you exceed this limit and you've got women on the floor, can you, as the premier hospital, turn some women away?
Well, where are they going?
That's the question.
Yes,
that's a specific question.
It's hard for us to turn women away.
So it means you have an open door, you cannot refuse.
Yes.
Women will pour in.
Yeah, women will pour in,
and the
but
capacity is not
beyond certain limit, we can't. And then it becomes a battle between the laboring mother and the staff. Imagine your wife being in labor and then comes to Korle Bu Teaching Hospital after being referred from somewhere and say that we are full, go somewhere as well. Okay. So at times it's difficult, but occasionally we turn some people away, I must confess.
So what are they to do?
Well,
are they turned away with proper referrals? Or?
Yes, what we do is that we try to communicate with other hospitals in town, say La Polyclinic, La General Hospital, Rage, military, other places. If they have space for them, then we arrange for them to go. If they don't have, then it's really difficult.
And they're left to?
Yes, we are left to take them. And they have to lie on the floor or to labor and then delivery.
Prof, just again on that, this is the normal, regular day.
Yes.
30, 35 deliveries.
35, 40 a day.
Right. I haven't touched on obstetric emergencies, women in critical condition that have been referred. I understand you have an obstetric emergency unit. Can you tell us a bit about the state of that?
Well, when we are talking about obstetric emergency, let us just focus on women who need cesarean delivery.
Okay.
Right.
As a case in point?
Yes, a case in point.
Right.
Right. Currently, there are 3 operating theaters in the department, but most of the time, only one is functioning. Why? The reason is that to operate on somebody, we need a team made up of doctors, nurses, anesthetists, technicians, laborers. In this country, anesthesia is, anesthetist, is an endangered profession in the medical field. So they are running shift such that we get fewer anesthetists allocated to the labor ward.
They're running shifts within the hospital.
Yeah, they're shifting.
Anesthetists. How many do we have? If you can share with us, how many do we have?
I don't think the physician anesthetists in Korle Bu are not more than 12.
12?
Yes, are not more than 12.
And they must service all the theaters?
All the theaters in the hospital.
Right.
Okay, they are not more than 12.
You don't get given priority?
No. Every area is a priority in the hospital.
Right.
Right. And so we get probably one of these physicians and anesthetists in a day.
Okay. If
And
I
they
can
are
get-
supposed to be, sorry.
Right, if I may understand, so that means that the two redundant theaters are redundant not because they don't have equipment, but you can't operate them with the full complement of staff. Is that what you're saying?
Well, that is also an issue.
Right.
Right. The equipment is an issue. Let us finish with that.
Okay.
So if we don't have them, and so we can only operate one theater
Okay.
a day. And then the equipment-wise, because of the high turnover, after each operation, we need to sterilize them. So if we are going to do on average about 15 to 20 of these, it means that you should have at least 10 sets to do the turning over the
Right.
sterilization. But we don't have more than 8 of these sets. So even if all the theaters are to function, we will still have some challenges. And therefore, women will have to queue waiting for cesarean section in an emergency situation.
Right.
You have a situation where a woman in labor has been told that the baby cannot come, or the baby's health is not that good in her uterus. It needs to come out quickly. And he's in a queue with 4 or 5 people ahead of her. And each of them will take about 45 minutes. After the surgery, they need to clean up. So that means that roughly about 50 to 75 minutes before they can reach your term. And if your baby cannot come and the womb is contracting, it's contracting against resistance. The likelihood of the womb rupture is also very high. If your baby's health is not good, the likelihood that the baby may die in utero is also very high. So when we come to such a situation, then it appears that we have to do some selection. And some women...
Literally play God.
Yes, right. And you look at your case and say that even though you are next to go, the person 2 or 3 behind you's problem is more
critical.
urgent.
Right.
Jump.
Right.
And some people may be lying, waiting for surgery for hours. Some may lie down waiting for surgery for about 8 to 12 hours, which is not very pleasant for anybody, either the patient herself or the staff. This is the situation that we are encountering with emergency obstetric care now.
Right. Okay. That's a grim and gory picture. Emergency with roadblocks. It defeats the purpose of the urgency or the emergency status. Dr. Kanlizi, I mean, you do a lot of work in this area. What are your initial comments? I dare say you are aware of some of these things.
Yes, thank you. I'm definitely aware of some of these problems. It's not only happening in Korle Bu, but even in the regional hospitals and other places you have it. However, what needs to be done has not been put in place over the years. For instance, Korle Bu is supposed to be our premier hospital.
That's right.
It's supposed to be a referral hospital. So complicated cases get referred there.
We should expect them.
That is what we should be
Prepare for
expecting.
them.
So it means that we should have other hospitals dealing with cases that are not complicated and are not getting referred to Korle Bu. In terms of distribution of doctors, and you would find that most of the hospitals outside of Korle Bu, there are few doctors there who perform emergency obstetric care. Take, for instance, cesarean section that he mentions. If, for instance, we did have doctors out there performing these operations, we would decongest Korle Bu.
Earlier, I talked about the paradox of an emergency situation with roadblocks and queues. And I'm coming back to you, Prof. This queuing and congestion, especially at what it's supposed to be or deemed to be an emergency unit, what addresses that? What should be done? A bigger unit?
Well, the Korle Bu Teaching Hospital was built, the maternity block was built in the 60s, when the Accra population was under 500,000. Now we have Accra population about 3 or 3.5 million. So it cannot serve the purpose now.
Right.
We need to expand.
Okay.
Should we expand within Korle Bu or should we expand outside Korle Bu?
Right.
That is a big question. We need to do probably both.
Right.
Increase the capacity of Korle Bu, as well as increasing the capacity and probably providing new polyclinics and some metropolitan hospitals.
Okay.
And then make sure that these new facilities that are coming up are also well equipped and well staffed with personnel. There is a training program currently going to train more specialists by the Ghana College. That is addressing the issue somewhat, but we need to improve on it. For Korle Bu Teaching Hospital, we should find a way to engage more anesthetists, more nurses, and then provide more.
What is that way? Is it attractive incentives?
Yes. Why should a nurse who has qualified from a training college decide not to work in Korle Bu, but go to another place? Why are people not going to the field of anesthesia to support the delivery of surgical services in the country? We need to look at this. People think that anesthesia is not attractive enough, and therefore the doctors are not going to that area of specialization. Of course, I would mention about equipment in the theaters. We need to upgrade our equipment. If you do that, and the 3 theaters are functioning, the congestion at the emergency cesarean section will go down a bit. But it may not be total. We may have to build another 6-story maternity hospital in Accra. I would suggest that that should be done at Korle Bu, since it is a teaching center, so that we can train all grades of health workers in this facility.
Prof, let me say, I mean, you're no mean personality, head of obstetrics and gynecology. At that level, I mean, you must have your interfaces with policy and policymakers and so on. Is it that this urgent need, and I see it as urgent, and the current situation, which I would want to label as unacceptable, is it that it doesn't resonate with the policymakers? When you say we need a new, maybe a 6-block maternity building, we need incentives for anesthetists, is it that they are not listening?
Well,
or they are not worried about the loss of life?
I don't think they are not worried. Everybody should be worried about loss of life, more so a mother. Right. They know. But I think the general economic situation in the country is also influencing what should be done.
How do we explain to the Ghanaian watching us that we have extra theaters, but they're shut down?
We in the department don't control the intake of anesthetists in the training program.
The health service.
The health services, the Korle Bu Teaching Hospital, the Ministry of Health are all involved, as well as the Department of Anesthesia. The Department of Anesthesia is saying that it's not attractive enough for young doctors to go into that field.
Right.
I cannot do much about that one. The policymakers will have to find a way to make that area attractive. Probably give them extra pay. You know, we are now practicing what they call free maternal care.
That's right.
Right. It's a very good policy, but there are so many shortcomings of it. What the insurance companies are paying us is about 40% of the cost of our service.
So there's a deficit.
There's a big deficit.
Right.
And for a long time, it's a government policy that for Ministry of Health and maybe all the public services, they pay only salaries and wages. You have to generate income to run your service. And from that goal, we are given 40% of our cost. And this is not coming regular. The last time we received our payment was July 2012. So we don't even have the money at hand to buy the so-called equipment we need to make the 3 theaters functional.
So your hands are tied?
Very much so. Okay. Then when this money comes in, the central administration will make sure that all our outstanding debts are cleared.
I guess you're getting the clear picture, but it's also sounding like, you know, a business venture, profit and loss. But we're really talking about human lives here. Dr. Kanlizi, I mean, you hear these operational challenges that bedevil even our premier hospital. I mean, can we shake this inertia off, or are we doomed?
Definitely we are not doomed if we sit up and try to address them.
Is this an issue of management?
There are management issues,
right,
but there are also certain bottlenecks
right,
that the premier hospital is beyond the premier hospital that has to be dealt with by the policymakers.
Let me just quickly come to you, Prof. I mean, from where you sit again, if I may put it this way, your biggest challenge or frustration in trying to save the lives of women in Korle Bu?
Right. let us look at the three main clinical causes of maternal death. One, hypertensive diseases in pregnancy.
Okay.
Two, excessive bleeding.
Right.
And three, complications of abortions.
Okay.
Right.
These are the three key drivers.
Three key drivers.
Right.
If we're able to control these three, I bet we will achieve the Millennium Development Goal before even the year 2015.
Right.
Right. Why are we not able to do so? If we are taking family planning serious, we will minimize the complications or eliminate it completely. Elsewhere, there is something they call pre-pregnancy counseling. I see the family planning centers as a very good resource base to do this.
Okay.
If women who are not ready for pregnancy are patronizing these centers, they will be appropriately be counseled on when they should embark on the pregnancy, even if they have a medical condition that will worsen during pregnancy, and reduce unwanted pregnancy.
Okay.
They will get services that will let them not get pregnant.
Okay.
And therefore, cases of abortion will go down. Now, if you come to hemorrhage, excessive bleeding during pregnancy, the blood banks in this country are almost always empty. And for bleeding in pregnancy, during delivery, it's not all that predictable. There are certain predictors, but in many cases, we are taken by surprise.
Right.
And we need the blood to replace. We have a policy that every pregnant woman that comes to our prenatal clinic, her husband or a close relative should donate 1 unit of blood.
Okay.
This is not going down where people are scared that when they take blood from them, part of their soul is gone. It's a misconception. Voluntary donation in this country is very, very minimal.
Abysmal, yeah.
If we can get blood at all times, about 30% of the maternal death will be cut off.
Doc, let me capture that again. So sitting at the Premier Hospital, you are saying that you are unable to guarantee safe, quality blood and blood products for pregnancy and pregnancy-related.
Yes.
So even in Korle Bu.
Oh, yes. How can we sit in maternity and get guaranteed that we always get the blood? It's not. Many times, relatives of dying women have been asked to go and comb other facilities in Accra for blood.
How does that make you feel as not only a doctor, the head of that unit?
It's very, very uncomfortable feeling, I must say. It's very, very uncomfortable feeling. We wish that we can get our blood bank in maternity block running and then well-stocked at all times so that we can take full control on unnecessary maternal death from bleeding.
Right. So that must be a major frustration.
Oh, yes.
A major professional and personal frustration. Right. Good. Okay. Thank you very much. That was you just been listening to Professor Samuel Obed on my right and Dr. Nicholas Kanlinzi of Engender Health. Clearly, there's a lot that needs to be done, and we have to put our shoulders to the wheel. As Dr. Kanlinzi said, we must sit up as a country and prioritize and make sure we implement the strategies that will save lives.
Next week, we will present the second part of our special report from Korle Bu and discuss the critical challenge of ensuring adequate blood supplies, why the constant shortages, and what can we all do to encourage more people to donate blood. Thanks for watching, and good night.